Good evening. Today's presentation for CME is entitled Management of Severe Carotid Stenosis, the Emergence of Transcarotid Revascularization. I'm Paul Armstrong. I'm presenting the standard speaker disclosure sign. I have no disclosures for this talk. Stroke risk is declining throughout the United States. Meta-analysis of over 30 studies shows that before the year 2000, there was a 2.3% per year ipsilateral stroke risk for the general patient population. Since 2000, that stroke risk has been reduced to about 1%. This in part is related to good control of blood pressure and hypertension management. There's now the widespread use of statins in primary prevention. Smoking rates are overall lower, and there are now stroke alert programs. Carotid stenosis is uncommon. Population estimates are about 1% of middle-aged and older adults. Similar estimates across a range of studies. The condition is strongly related to age. In people less than age 50, there is a 0.5% chance of carotid stenosis in men and 0.3% chance among women. In persons aged of greater than 80 years, that percentage chance is quite substantially higher, 5.7 and 4.4% respectively. The current contemporary therapy for carotid stenosis is a three-pronged attack. Guideline-directed medical therapy consists primarily of lifestyle modifications and risk reduction. Carotid endarterectomy remains the gold standard for most circumstances, but there's been the emergence of carotid artery stenting over the last decade and a half, and more recently in the last 5 years, transcarotid artery revascularization, also known as TCAR. Guideline-directed or intense medical therapy includes improvement in control of hypertension. Each 10 millimeter drop in blood pressure decreases stroke risk by about a third. LDL control as well is important as stroke risk drops greater than 15% for each 10% drop in the patient's LDL. Statins decrease the risk in up to 30% of patients. Smoking cessation also decreases the risk as well, with current smokers experiencing almost a 4-time increased risk of stroke based on American Heart data. What about the primary care perspective regarding evaluation of carotid artery disease? Well, most primary care groups or organizations as a whole say that carotid stenosis greater than 75% is uncommon. Therefore, general screening offers poor prediction of disease. Targeted screening is yet unproven in most patient populations. There have been marked improvements in medical management, so routine screening is not indicated. And there are better uses of healthcare resources rather than screening for carotid disease. Those proponents who argue this situation is whether or not we should have routine evaluation for certain subgroups of patients with active atherosclerosis suggest that screening may be beneficial in these subgroups, especially if they have certain risk factors, including age and active tobacco use. There is a low risk for intervention when it comes to treating carotid disease, so the outcomes can be improved with a low overall patient risk. And there could be improvements for intense medical management if we do screen for the disease and we identify it early. For about the last 3 decades, this has been the basic carotid atherosclerosis algorithm. For symptomatic stenosis, the algorithm on the left shows you that symptomatic stenosis should be converted to inpatient admissions. Stroke neurology consultation should be obtained. This is the basic stroke alert protocol that we see in our emergency rooms. Less than 50% of stenosis, we then take those patients and push them towards medical management. guideline-directed therapy, and disease surveillance. Whether or not you involve a vascular surgeon for consultation for asymptomatic disease is usually provider-specific or hospital-specific. For greater than 50% stenosis, we still offer those patients operation. So consultation with vascular surgery is most appropriate if you have that condition facing you. Surgical education, cardiac risk assessment, and then consideration for carotid endarterectomy or carotid stenting would follow after patients have been deemed symptomatic with disease of at least 50% stenosis. For asymptomatic stenosis, we essentially don't look at disease that's less than 50%. But for those patients who have 50 to 75%, we then take them down a pathway that's similar to that of the inpatient, where they would probably receive a vascular surgery referral in the outpatient setting, and that referral would further strengthen medical education for the patient relative to their disease, importance of maintaining guideline-directed medical therapy, and provide disease surveillance with serial ultrasound at some designed interval. If a patient has greater than 75% asymptomatic disease, then that outpatient vascular surgery referral would likely provide the patient surgical education, cardiac risk assessment, and then proceed on with carotid endarterectomy or carotid stenting. What about the patient expectations for carotid intervention? Well, patients expect basically the following 8 things to happen. First of all, they'd receive a standard preoperative cardiac risk assessment, whether the patient's being considered for stenting or for endarterectomy. They will receive routine preoperative testing at the admitting hospital. They would likely be admitted for same-day procedure if they were outpatient, or converted towards an inpatient procedure in the next 1 to 2 weeks if they were inpatient and symptomatic with the condition. General or regional anesthesia can be provided to treat the condition. Postoperative ICU care in uncomplicated cases is typically 1 day. They're often home on their first postoperative day. They're allowed to shower and have regular activity in somewhere between 24 and 48 hours. And they usually are maintained on dual antiplatelet therapy for the first 90 days, and then lifelong single antiplatelet agents as per physician recommendation. What about carotid endarterectomy? Well, again, the gold standard. Most of this work is based off of studies that originated in the late 70s, were carried out through the 80s and 90s. In this country, we have basically 3 large randomized controlled trials, and we base most of our care on that. So it has a good history and track record, if you will. Consistent outcomes have been noted across all degrees of stenosis, greater than 50% in these studies and in more recent studies. Historically, these studies were done with high-quality surgeons, and there was low-quality medical therapy. For instance, statins weren't around in the 70s, 80s, and early 90s. Risk of stroke does decline over time with intense medical therapy, and so there have been questions as to whether or not carotid endarterectomy should still be called the gold standard. And this is a point of ongoing research amongst the larger randomized controlled trials and databases in this country and the world. Surgical risk seems to be declining, however. Therefore, there is the question as whether medical therapy will be more superior to carotid endarterectomy as the risk of complications with the surgery is low. It's uncertain as to whether the guideline-directed medical therapy therefore will catch and surpass carotid endarterectomy, and this is essentially a circumstance that is yet to be answered. Who should be providing carotid intervention? Well, this is a 2018 study that looked at single-center high-volume carotid programs. There have been multiple other studies that have shown similar results. The basic conclusion from this in regards to carotid stenting and carotid endarterectomy is that these procedures can be performed with excellent outcome by vascular surgeons at a large volume hospital. And so you'll see there that the numbers, there is not too much difference in the 3 major endpoints that we look for when we do these type of procedures, and that includes stroke, myocardial infarction, and death. In the last decade, we have developed large contemporary carotid registries. This pattern has been copied from what we've seen in Europe, and we now have in this country several large registries in which we can enroll these type of patients to determine whether or not we're providing best medical therapy or best surgical therapy for this condition period. The first article here mentioned here included 21 registries across the world, 1.5 million procedures, and the conclusion of that registry regarding the stroke and death rates following carotid artery stenting and endarterectomy showed that clearly carotid artery stenting has a significantly higher stroke and stroke death rate than carotid endarterectomy. And it often exceeds those accepted American Heart Association thresholds that we publish and tell our patients about. There was no evidence that there was sustained decline in procedural risk after carotid artery stenting. And this is a little bit different than what we have seen with carotid endarterectomy, because clearly the carotid endarterectomy trials published in the last decade differ drastically in regards to outcomes as it relates to those studies published 20 or 30 years ago. The second study mentioned here is a meta-analysis of procedural risks of carotid endarterectomy and carotid artery stenting over time. This is about 51 registries, again, across the world, about 300,000 procedures. The conclusions here were that the risk of procedural stroke death following carotid endarterectomy appear to have decreased substantially, and there is no evidence for change in the stroke death rates following carotid artery stenting. So again, both these studies suggest that carotid artery stenting may not be as good as carotid endarterectomy. And this prompted ongoing research as to why these differences exist. CMS has identified what we consider high-risk surgical patients for carotid intervention. And I've highlighted for you here some of these in red. These in red are what most current and contemporary vascular surgeons would consider are good reasons for performing carotid stenting. And they include patients aged greater than 75. This in part based on the data that's shown from the original CREST trial and subsequent sub-analysis of that trial. They also include prior head and neck surgery or radiation, restenosis after carotid endarterectomy, surgical inaccessible lesions or high lesions as we like to call them, and permanent contralateral cranial nerve injury or contralateral carotid occlusion. In regards to the data on carotid artery stenting, we've got about 17 years of good international transfemoral carotid artery data. And as you noted from those previous two studies that cited 300,000 and 1.5 million patients, we have lots of patients. The problem with transfemoral stenting is you must engage the aortic arch. And it turns out that many of these strokes are indeed related to establishing a platform in order to get the carotid stent in place. This had prompted investigators to develop different patterns of access as well as patterns of filter or cerebral protection that we could develop and use to decrease that stroke risk. Thus ushered in a newer procedure, TCAR, or transcarotid artery revascularization. For that, we have about 5 years data and around 900 patients and active VQI database, as most patients, especially asymptomatic patients, are required to be captured and placed into a database that can be reviewed on a regional and national basis. What about cerebral protection? Well, we've had advances in that as well. The original cerebral protection for carotid stenting was that of a filter device, as noted in the picture above. However, more recent flow reversal technologies have come forward that seem to be valuable in reducing even small aggregate emboli to develop. And maybe the most popular current one associated with the TCAR procedure is the in-route neuroprotection device, which is a low resistance AV circuit that actually involves reversing the flow in the common carotid artery and depositing that flow into the common femoral vein system. Thus, about 5 years ago or so, the TCAR investigation was launched based on this need to reconsider how we might manage some of the more complex lesions associated with carotid atherosclerosis. And as most investigations start, they have a original enrollment. And if you come across these names, that's the reason I put this slide forward so you'll have some idea. The first study began in 2011. That was the PROOF study, enrolling 43 patients. They used diffusion weight MRI in order to identify whether or not there were complications or new lesions associated with this study. They found that similar to CEA, the amount of hits or embolic lesions associated with the use of TCAR was only 1.7%, but this was markedly different when compared to those patients who had transfemoral carotid stenting. As you see, their numbers were somewhere between 45 and 87% when you look at similar type testing done in the literature. So the PROOF study, as a lead-in, suggested that this type of reversal of flow procedure might allow for less chance of embolic, either asymptomatic or symptomatic emboli to develop. Their second trial was the Roadster trial, 219 patients. 42% of those were considered in the high-risk group, greater than 75 years of age. They did have about a little more than a third of patients were female, which some of the older carotid endarterectomy studies lacked. They lacked a female arm, if you will, to assess how women favor in regards to some of these procedures. There was 99.5% technical success rate, which is a high technical success rate for any carotid stenting procedure. The stroke death and MI rate was 3.7%, stroke rate 1.4%, temporary cranial nerve injury was 0.5%. So again, less than what we would expect overall for this circumstance. The final was Roadster 2. 2019, their final study. It's the post-approval study. 30-day outcomes were provided, and one-year results were recorded in addition. Again, a very low stroke death and MI rate, 1.7%, 0.8% stroke and death rate. Again, very low, even lower than most of the most recent carotid endarterectomy trials. And overall, it seems that this is a very safe way to approach carotid disease. And this prompted even more investigation. All these three studies here, as mentioned, are all part of the company's trials. And so they are investigator driven by the company who makes TCAR, which is called Silk Road Medical. Here are maybe three of the more important trials that have been done in the last several years, or summaries of trials, if you will, and they can compare different things. The first trial that I have mentioned here is a transcarotid artery vascularization TCAR versus carotid endarterectomy. And as you see here, the 30-day stroke and death rate was very comparable between the two procedures, 1.4 and 1%. The one-year stroke and death rate, 4.6 and 6.7%, although the p-value was not specific in that. There is about just shy of 600 patients in this particular comparison that was done in 2019. And the cranial nerve injury rate obviously was a little bit different. So that's favorable as well. So the goal of this study, or the final conclusions, I should say, was to say that the two procedures are comparable to each other, and one does not have a clear superiority over the other. Although the nerve injury thing obviously had a p-value, it's considered not to be a major outcome that we follow in general for these procedures. The second study just to the right of that is a transcarotid artery TCAR stenting versus transfemoral carotid artery stenting. assessment. This compared around 638 TCARs to about 10,000 transfemoral stenting. This is a VQI type study where we have registry and database type study. The higher risk after transfemoral carotid artery stenting is 2 times that of TCAR for stroke and TIA, and stroke, TIA, and death. So an interesting finding, if you will, for stroke and TIA, and obviously suggesting that TCAR is a safer alternative to transfemoral carotid artery stenting, and correlating with the previous made point that the aortic arch is a risk zone for developing embolic event during transfemoral stenting. The final thing to point out to you is most recent 2020 study done looking at the impact on hospital outcomes after transcarotid artery revascularization as compared to transcarotid artery stenting and carotid endarterectomy. So TCAR was directly compared to these 2 procedures. This was solely using the VQI initiative database that was provided. Most of this database actually originates in the northeastern part of the country. However, there are other large contributors to that as well in the south and in the Atlanta and Birmingham region. Here in Florida, we're actually a fairly large contributor to this as well. So at least in the eastern half of the United States, we're by far the largest contributor. And that would sort of go along with how healthcare is distributed through the country, with the eastern half of the country providing a large volume of healthcare. Although places in Texas, Arizona, and California also participated with large volume numbers in this as well. So the study itself showed that in regards to carotid endarterectomy, that there were no significant differences. And the final conclusion is that TCAR seemed to be equal to carotid endarterectomy and should be considered in patients who don't have bulky calcific circumferential plaque disease. And then transfemoral carotid artery stenting, however, did not compare favorably to carotid endarterectomy, and also did not therefore compare favorably to TCAR. As patients greater than 80 years, TCAR was a safer circumstance than transfemoral carotid artery stenting. And the long and short of it is that transfemoral carotid artery stenting should probably be our third choice of how we intervene on patients with carotid occlusive disease that requires surgery. So if I can set up for you how this sort of looks, most of this is cartoon related, if you will. The TCAR setup itself involves a sheath, and it's a specialized sheath made by the Silk Road Company. It goes into the neck through a small open transverse or longitudinal incision just above the clavicle. It's through this incision, we perform angiography, cross the lesion, deploy the stent, do balloon angioplasty, etc. Prior to doing any intervention, we also set up the reversal of flow system, which is essentially a tubing system that's shown here, extending from the neck down to the groin. In the groin, a sheath has been placed in the femoral vein, and the reversal of flow happens according to the pressure gradient of the body as arterial flow is shunted into the vein here. This picture here in the center here shows what would be the filter. There are 2 buttons here that allow you to interrupt flow so you can perform angiography, and this filter here captures debris should debris happen during any portion of the procedure. A little more realistic look in regards to what it looks like on the neck. Here's a transverse incision with the first generation sheath in place. And then in the groin, we do ultrasound for the groin picture here. This picture at the bottom here is a picture of the debris that the filter caught as it relates to the reversal of flow. So the nuances of the procedure are that you can be a little more aggressive with management of balloon angioplasty with this reversal of flow and catch some of that debris. How do hospitals credential for TCAR providers? There's essentially 3 ways that providers are credentialed for this. The first way is that a surgeon themselves has done more than 5 TCAR related procedures. They have endovascular procedures with rapid exchange technology being utilized, and those surgeons have active endarterectomy privileges at the hospital. The company itself that provides TCAR training to allow you to learn how to do the TCARs, and so that's already been completed, and those persons essentially need no proctoring, and they can be credentialed at your hospital to do a TCAR. The second way is for those surgeons who have not had a TCAR experience. They have less than 5 TCARs and greater than equal to 25 endovascular procedures, including monorail type rapid exchange platforms. Those surgeons also need to be credentialed, obviously, to do endarterectomy. They also go get the similar training as to the surgeon with experience, but they usually get a proctored 5 cases. And once they've been proctored in 5 cases to a satisfactory extent, they can then become credentialed as TCAR providers. The third means by which people become credentialed in TCAR is that they team up with a person who has expertise. For instance, in this case, a surgeon who has carotid endarterectomy privileges but may not have all the endovascular skills or privileges would team up with an interventionalist. Those people would together perform a team approach, and they would do 5 TCAR cases with some supervision, and then they would be credentialed to be TCAR providers. So the steps and processes to learn the procedure are pretty straightforward and have been validated in multiple centers and can be easy to do. I like to say for almost any type of training, I like to use the Michael Scott learning curve for that. Mike starts out, as you know, he doesn't think he knows how to do anything, and it's super hard, and he's real dumb about it. And then after a few more procedures, Mike realizes that learning is fun, and he can do it. And once he's done enough procedures, he's going to strive for excellence and be an important provider for new technology. And so the TCAR, it turns out that the TCAR type of training and so forth seems to follow this curve pretty well. Unlike some other types of training, TCAR, I think, has some important points that should be followed. So Silk Road Medical has developed an entire kit for this. They have all the components with the exception of balloons. So using their kit, clearly has thought of the most integral and important steps of the procedure and provides for a safe treatment algorithm. And I think that was well outlined by their lead-in and follow-up studies with Proof, Roadster, and Roadster 2. Case planning for these cases is key because there are some circumstances where supraclavicular access to the carotid artery is not suitable for carotid stent placement due to common carotid artery length or lesion length. Some lesion characters are harder to treat than others, such as circumferential calcium. So therefore, planning is important and typically done with a CT scan, although experienced providers could provide the procedure with proper ultrasound interrogation and assessment preoperatively. An individualized anesthesia plan can be provided for the patient, as the procedure can be done under local or with general anesthesia. And a second set of hands in general is important for this because there are obviously wire and catheter exchanges. So 2 sets of hands tends to be helpful. What I would say to you from having proctored persons for this procedure as well as learning it myself is that you will want to yield to the company's recommendations regarding training and regarding how they use their product. And you would want to monitor providers' endovascular skills as they learn TCAR. And this can be done obviously with company representatives. The company's very good about sending their clinical reps to cases, as well as for established proctors at your facility. And it depend on the experience of those proctors, because in general, the carotid artery stenting is not necessarily as easy as some other vascular beds we participate in. There are a few program barriers to starting this program at your hospital. One of those is that symptomatic disease can be treated pretty straightforwardly without any particular registry concerns or enrollment concerns, and CMS tends to pay for that appropriately. There is the issue of getting CMS to both pay the physician and the facility appropriately when it comes to providing carotid stenting, and the experienced providers will know that. Asymptomatic disease required VQI registration, so the company has made a commitment to registering these patients on a national basis, and this has helped the FDA as well as CMS provide for what I would call reasonable reimbursement for the procedure. So your facility would have to participate with VQI in order to manage asymptomatic disease, and likewise you would be enrolling the symptomatic disease in VQI type registry as well. So that sort of concludes the basic discussion about TCAR, transcarotid artery revascularization, and where we are in 2021 in regards to managing severe carotid stenosis.